Thank you, Dr. Nehakakar, Dr. Redga Patil,
Yeah, thank you, sir.
and and those in the English Hindi session. Good
Okay.
evening, good afternoon, and good morning. This is the 2031st day of continuous webinar conducted by International Forum for Promoting Homeopathy. Today, our guest is Professor KULWANT SINGH. Let us begin the session with 1 minute silent prayer. Thank you all. The International Forum for Promoting Homeopathy comprises of homeopathic lovers, students, and doctors, and we have 3 sessions every day. First session of the day is already over in Hindi from 7:30 to 8:30. From 8:30 to 9:30, we have the international session in English, and from 9:30 to 10:30, we have a local language session in Malayalam. We are uploading the videos of the same on the very next day itself so that those who miss the session can watch it again, and you can subscribe the same without paying any money. You can share the videos with your friends, whether it be a homeopathy lover, students, or doctor. It doesn't matter. What matters is to take homeopathy to every home around the world. And let me come to today's guest. As you all know, we have a wonderful guest today, Professor Dr. Kulwant Singh has completed D.H.M.S and then MD in homeopathy and was the ex-dean, faculty of Vinabhave University, Jharkhand, and is the principal Singham Homeopathic Medical College and Hospital, Jamshedpur since 2000, and is having more than 44 years of teaching experience and professor SM, SHM College, and has presented several seminars nationally as well as internationally, and is one at Arab Conference in Dubai in 2014 as a resource person of Ayush in different sections, and is ex-chairman Homeopathy Literature Committee CCH New Delhi and ex-member Education Committee CCH New Delhi and PG Guide Rajasthan Vidyapeeth Udaipur, Bihar University, and ex-inspector Central Council of Homeopathy, New Delhi. And the sir has presented so many sessions in this forum, and today sir is about to present a very important subject and a very relevant subject, that is peptic ulcer and homeopathy. We proudly welcome the guest of the day, our Kulwant Singh sir. Welcome, sir.
Thank you very much. Am I visible?
Yes, sir. Audible, sir.
Oh, my screen is not coming.
Some sound is not proper, sir. Can you raise the sound a little more, Ole?
I'm trying to do that.
Okay, sir.
Okay, thank you so much.
That's how the.
Thank you, Dr.
Yes.
Dharesh, for giving me this chance once again. And this, I was very confused when I selected this topic because this is a topic which is so common in practice life, and everybody knows a lot about it. I was unable to think that what should I tell? All qualified doctors, all senior doctors are there. But we will try, let us continue with the learning process. So peptic ulcer is the name indicates that it is an ulcer in the digestive tract, most commonly in the stomach and in the duodenum. That is duodenal ulcer and gastric ulcer. And 5 cardinal signs for the ulcer are starting from P. Peptic ulcer from P, there is pain. The pain is mostly epigastric. Sometimes just below the epigastrium, spreading to the abdomen. There is puking, nausea and vomiting. There is protuberance. Protuberance is bloating and fullness in the abdomen. There is pyrosis, heartburn, acidity, and there is positive FOB, positive fecal occult blood test. This is very common in case of duodenal ulcer. So something about the history. The history indicates that during 1500 BC, there were patients who were having the similar symptoms, but the name was not given like gastric ulcer. But the Ebers papyrus is the literature, medical literature, they describe symptoms of severe abdominal pain, indigestion, and vomiting to so many patients. And in 1000 BC, the people believed that this was an act of a demon, punishment by the gods. So they always worshipped the god. They always asked for the clearance and the guidance from the god. You can see demons, and they tried to understand the condition of the ulceration. But it was a miraculous attempt by Dr. Marsh and Dr. Robin Warren, Dr. Barry J. Marshall and Dr. J. Robin Warren. They were actually previously there was a belief that the ulcer is always happening due to something which is very corrosive, very acidic, very harmful when the person eats something, and then there is causation of ulcer. But they had a belief that it is caused by some bacteria or other. So for some bacteria or other, you will have to give antibiotics. And in those times, antibiotics were strictly forbidden in cases of ulcer. So they thought that antibiotic will aggravate the conditions. So by research and experiments, one day, Dr. Marshall, to prove causation, Marshall drank a culture of H. pylori in 1984, developing gastritis, vomiting within days. And the biopsy confirmed that there was an infection, there was a bacteria, and this experiment confirmed that the bacteria was the main cause of gastric or peptic ulcer. And later, they keep on experimenting and they named the bacteria Helicobacter pylori because of the shape. They cultured the shape of the bacteria. This was the shape. So it was just like helix, spiral in shape with a lot of flagella. This is the flagella. So there are a lot of flagella there. So they named it Helicobacter pylori. And the best part of it was that in the year 2005, their discovery, which they made in the year 1980 plus, 84, but in the year 2005, they were awarded Nobel Award for this discovery. So most of us don't know that we study that it is caused by H. pylori, but we are not aware that this experiment gave them the Nobel Award. And the title was The Bacterium Helicobacter pylori and its Role in Gastritis and Peptic Ulcer Disease. This was the title on which they were given Nobel Award. These are the small bacteria that are enlarged 1000 times. You can see these small structures. These are small structures. You can see these small structures, and they are the bacteria. Under microscope, where it was enlarged 1000 times. Now let us come to the most important part of it, that what is the mechanism by which H. pylori affects the intestine and there is causation of gastric or duodenal ulcer. So there is first, these bacteria, they get entry into the intestine. You can see they get entry into the stomach lining, entry via contaminated food and water. This bacteria is entering the intestinal wall. This penetrates the mucus layer and attaches to stomach lining. So this bacteria enters the intestine through contaminated water, through food and other products. It enters the intestinal lining, and we will discuss later how it survives. We know that the medium of just a second. So we were discussing that how does it survive in the stomach? We know the medium of the stomach is strongly acidic. So if we know that strong acid destroys the bacteria, destroys so many things. So, but it survives. How? We will try to understand this. survival in the acidic medium. How does it survive in an acidic medium? So it secretes an enzyme which is known as urease. The bacteria enters and it secretes an enzyme which is known as urease. And urease, what happens? Using its flagella, it enters the intestine, and the survival is there. See, the pH, the acidity level of the stomach is 1 to 2, which is strongly acidic. The area below that layer is about pH is 7, which is alkaline in nature. So the bacteria wants to go to that level where the pH is high. And how does this happen? It secretes an enzyme which is known as urease. And urease is broken down into urea, ammonia, and carbon dioxide. Urea is again broken to ammonia and carbon dioxide. There's a fantastic way of nature how it survives. So when there is formation of ammonia and carbon dioxide, they form a cloud. They form a defensive cloud outside the H. pylori, and the way when the acid does not act on it, and they survive and they penetrate the stomach lining, and there is formation of, you can see, there is pH change. The pH is 0 to 1 in the upper level. There is mucus layer damage. There is tissue injury and ulcer when the pH changes doesn't affect. And there is a protective ammonia cloud, which I discussed just now, that there is a protective cloud outside the bacteria, and it prevents any action on them, and they develop and they grow. Just watch this small animation, you will understand everything. It may take few minutes. This is the mucus layer. This is the stomach lumen. The mucus lining is there. This is the pH 7, the alkaline layer. There is the pH 1 acidic layer. This is gastric juice layer where the acid is very high, and below it is pH 7, the alkaline layer is there. Now, when the bacteria gradually enters the stomach lining, you will see the bacteria coming. These are the columnar epithelium of the stomach. And you see now the bacteria is entering, H. pylori is entering the mucus lining of the stomach. And there is urea. This urea is being broken down into ammonia. Urease is there. It breaks down into bicarbonate and ammonia, and they are forming a cloud, you can see. See the cloud. So this is the cloud which prevents the action of acid on the bacteria, and thus they penetrate the stomach lining, they secrete cytokines, poisonous substances, and there is formation of ulcer here. So this is the basic process by which H. pylori is causing an ulcer. This is the very important thing which we must know for the practice life, and our understanding also that how a bacteria which should be killed by the stomach acid is not being killed there, and gradually formation of ulceration inside the stomach lumen. And this theory is the most important theory nowadays. We must understand this because this we cannot explain the formation of gastric ulcer. That is known as gut dysbiosis and peptic ulcer. Nowadays, there are so many diseases which are directly associated with dysbiosis of gut. Dysbiosis means mismanagement. There is disturbance in the normal environment of the stomach. So how does it get disturbed? There are good bacteria, there are bad bacteria, there are other so many things in the stomach which ultimately they have a balance. They have a mechanism by which this is balanced, and this balance continues to maintain proper health. but due to some disturbance in dysbiosis, there are chances of formation of so many diseases, and the most common of them, because it is directly related with the stomach, and that is peptic ulcer or gastric ulcer to begin with. So there is imbalance of gut microbiota. There is disturbed gut flora weakens the defense. If there is disturbance of the gut flora, it disturbs the imbalance, disturbs the balance of the normal gut bacteria, and this results overgrowth of harmful bacteria. I told you that there is good bacteria, there is bad bacteria in the stomach. But if there is imbalance of gut microbiota, it helps in the overgrowth of harmful bacteria. So pathogenic microbes increase. These pathogenic microbes may be H. pylori, may be other things also. But normally this is the phenomena, this is the process by which there is overgrowth of harmful bacteria. And if there is H. pylori, there is enhanced H. pylori survivor, favors H. pylori colonization. Because of the overgrowth of harmful bacteria, the normal acid which is in the gastric juice is not able to kill all the bacteria, and the bacteria overgrow with their own help with the formation of urea, ammonia, and urea. That is one factor. Second is there is over colonization of the microbes, and gastric acid is not able to kill all the bacteria inside. So there is damage to mucosal barrier. This is the most important point. The gastric mucosa, it is having its self-defense mechanism. So if it is not working properly, what will happen? The mucosal barrier defense will be damaged. And surprisingly, nature has given one chemical in the stomach and duodenum, which is known as antipepsin. Antipepsin is a chemical or hormone-like substance which helps to prevent the action of pepsinogen on the mucous membrane. So pepsinogen is helping in digestion of the protein. We know that if pepsinogen is digesting the proteins, why it is not digesting the stomach layer which is made of protein? Very surprising. What we eat, we eat meat, we can digest that. We are eating protein, we can digest it. Gastric mucosa is made of protein, but it is not being digested by itself. So the real cause is presence of antipepsin-like chemicals which prevent the action. And if that is reduced, the action, the prevention is reduced, it will be very difficult. So there is altered immune response. Due to these problems, the immune response is weakened and there is increased gastric inflammation that is known as chronic gastritis. The bacteria, they enter into the mucous lining, they secrete toxin substances, and they increase the inflammation in the gastric mucosa, and that there is inflammation of the gastric mucosa. One more, there is reduced protective metabolites. There are some metabolites which are protective for the layer. One of them is SCF, we can say, that is short chain fatty acid, SCFA. So these short chain fatty acids which are present in gastric mucosa, they help in the prevention and protection of the gastric mucosa so that H. pylori or any other acidic things cannot harm the gastric mucosa. But what happens? If they are reduced, there will be action. The same is, there is presence of nitric oxide in the mucosa. So if dysbiosis is there, they can alter nitric oxide production and they affect the blood flow to the gastric mucosa. If the blood flow to the gastric mucosa will be reduced, the immune response will be reduced, the action will be reduced, and it will be open to the action of toxins. It will be open to the action of H. pylori-like bacteria. And plus one most important part is synergistic with NSAIDs. You see, NSAIDs, non-steroidal anti-inflammatory drugs. People are using them in plenty. So they go into the linings, they aggravate the lining, they weakens the lining, mucosal lining, and in the long run, if a person is taking for a very long time NSAID medicines, it is prone to formation of the gastric ulcer. And all these factors combined, they delayed ulcer healing because the immunity level is low, because the production level is low, because the medium is not responsive or not productive for gastric acid medium. So there is gradually there is formation of gastric ulcer. So this is a very, very important theory which is acceptable universally, and that is the best theory which is acceptable for formation and disturbance in gastric ulcer. Now, let us see how this gastric secretion is there. So there are basically two types of glands in the gastric mucosa. One is auxenting gland, one is pyloric gland. You can see auxenting gland, pyloric gland. Auxentic glands are in the fundus and body of stomach, and these are pyloric glands. They are present in pyloric antrum. Just where the duodenum is going to start and the stomach is ending, that part is pylorus. So pylorus, these glands are in pylorus. There are three types of glands: mucous neck cells, which secrete mucus. There are peptic cells, which secrete pepsin. And there are auxentic cells, which secrete hydrochloric acid. In pyloric glands, there are mucous glands. These are the mucous glands on the top, which secrete mucus. The second layer is pepsin. Third layer is known as gastrin cells, which secrete gastrin. And all these are responsible for the maintaining the proper balance. And gastrin cells, they are mostly endocrine cells, and they secrete gastrin into the bloodstream. And gastrin stimulates HCl secretion and gastric motility. So any disturbance in the function of these glands are there will be some problem in the stomach. One of them, the most important of them, is gastric ulcer. Formation of ulcers in the stomach. Causation, I have already told you. So now we'll have to discuss or know that what are the factors which are causing this problem. There are some factors which are some are aggressive factors, which our diet habit is there, something of that kind is there. And second factor is the lack of defense. So let us start with the etiology, which is having aggressive factors. So there are so many very common factors which are responsible for, which is aggravating, which is causative factor for the formation of, which are aiding the formation of gastric ulcer. The most important, I told you, the medication, especially NSAIDs, because NSAIDs are being taken very commonly by everybody. Which be medicines, you just take a NSAID or painkiller or something like that, anti-inflammatory painkiller, so you will be better. But this gradually disturbs the stomach lining and creates bleeding. Second is smoking habits, tensions. This impairs healing and increases acid production. So that we'll have to take care very strongly. The third is tea and pepper. Tea in large quantity will irritate the stomach lining and increase acid. I always suggest my patients that if you are having in this side, people drink tea in plenty. So we just request or advise the patients that before taking tea, you must drink water. Because tea will go to the stomach and irritate the stomach mucosa. If you drink some water before taking tea, it will sometimes help. Because there are patients, they will never leave tea, they will leave the doctors, but they will never leave tea. So they are happily taking tea. It's very common in these side of area. So we should avoid tea, coffee, pepper. Pepper is also one factor. These are the medicines, especially these are the chemicals which are found in chocolates. Methyl xanthines. So these chocolates are very common in other countries, not in India. Now it is becoming more common in India due to publicity and TV. But they contain some chemicals which can increase acid and cause severe irritation. Next, hydrochloric acid, we have already discussed that excess of HCl secretion in the stomach will cause formation of gastric ulcer, because if the ulcer is more, if the acid is more, acid is coming, so all the defensive mechanism will not be able to neutralize the acid, and the acid will start acting on the membranes, causing ulcer. Empty stomach for long time. This is in India, this is a religious thing where our ladies believe in fasting. They are having a lot of fasting festivals or process in the family. And as this is a religious thing, we cannot avoid. We cannot say them, no fast. But if a person is regularly fasting, this may cause the irritation of the gastric mucosa and potentially harming the stomach lining. So if such patient comes, we should advise them very politely that this is your situation, this is harming you, please take care. Ethanol consumption, very obvious. Ethanol is it irritates the stomach lining, increases acid production. Caffeine. All these are very common factors. You see, very common aggressive factors which are very regular in day-to-day life, day-to-day practice. And if we can control these things, we can control formation of gastric ulcer in so many patients. These are due to lack of defense factors. There are causes which are due to lack of defense factors. What is the defense mechanism of the system? So there is the presence of prostaglandins. Prostaglandins normally are chemicals, they are hormones secreted from fatty acids, and they protect the gastric mucous lining. So if prostaglandins comes low, the linings will not be safer, and there is chances of formation of gastric ulcer. So these are most commonly destructed by NSAIDs, painkillers. Strong painkillers, they reduce the secretion of prostaglandin, and when they reduce the prostaglandin, there are chances of formation of gastric ulcer due to the lack of strength in the gastric mucosa. Second is the gastric barrier. I told you last time also that gastric barrier, when this barrier is damaged by infection, drugs or stress, acid can diffuse back into the mucosa. Gastric mucosa is having its own strength, its own barrier, but if it becomes weak due to some reasons, so these reasons can be some infection, drugs, tension, lack of proper diet, lack of proper timing of the diet, and sometimes lack of antipeptic. If there is all these are lacking, there are chances that the resistance, the power of the mucosa will be reduced, and the patient will be having maximum chance of peptic ulcer. Next is the blood flow. You know, the defense mechanism is taken care by the blood only. So if the blood flow is reduced by any reason in circulation, so that will weaken the mucosal defense, and ultimately it will be open to formation of ulcerations. So reduced blood circulation weakens the mucosal defense, and there is cellular renovation. Cellular regeneration is impaired healing of the mucosa flow. We know, all of us know, that all the cells are they are normally renovating itself, like skin, like inner side cells. They die and new cells take their place. If this process is slowing down by some reason or other, so if this process slows down gradually, if this process slows down, so the mucosa will be open to minor injuries by the medicines, by the acids, by other things, by alcohol. So many things. So if the renovation is not proper, it will be open to injuries by other factors, and this will cause gastric ulceration. There are these 5 types of peptic ulcers normally found in our system, and the most common are these 3. Esophageal ulcer, less common. Gastric ulcer, most common. Duodenal ulcer is also very common. So these 3 are the main types of ulcer found in the gastric layer. One is marginal ulcer, less common. Michel's diverticulum is a condition, congenital condition, when the mucosa is open for formation of gastric ulcer, because it is a pouch which comes out from the intestine. So it is not common, very uncommon. But there are instances when a person is having Michel's diverticulum, it is having chance for formation of ulceration. I'll show you some endoscopic pictures of because they are inside the stomach, so we'll have to see how does they look. This is an esophageal ulcer. This is the esophagus part, and you can see these are the formation of ulceration. These are the ulceration. It is just above the esophageal cavity, so they are known as esophageal ulcer. The next, the most common is gastric ulcer. This is the stomach opening, and you can see the severe ulceration here. So these are, and you see, if you can understand the endoscopic reports, sometimes they are very useful for selection of medicine. And outer side, you are having symptoms, the patient will complain there is pain, sometimes pinpointed pain, calibichrome, sometimes indigestional pains with this nux vomica, sometimes severe acidity, robinia. The patient will give you so many symptoms. But if you see this kind of patches, we will discuss later that there are some medicine which will direct you for selection of medicine on the basis of the ulceration, of the basis of the types of ulceration. See duodenal ulcer. This is the duodenum and a severe ulcer, very severe ulcer. This is not very severe, but these are the ulcerative patches outside the duodenum. So this kind of a look is very serious, and this may lead to puncture, perforation. If the ulcer is this severe, this may lead to perforation of the duodenum. Very, very serious condition. Patient will die if there is perforation and not being treated properly. So as I told you, there are these pictures sometimes will help you in selection of medicines also. This is the marginal ulcer on the margins. These are on the margins, but they are not very common. But just I showed you the picture that there are marginal ulcers which will be found here. And this I was discussing, the Michel's diverticulum. This is the part of the intestine. There is a growth, small pouch coming out of intestine. This is congenital. You can see this pouch is there. So sometimes this pouch is having gastric mucosa inside it. Normally it should not be there, but now sometimes it's having gastric mucous membranes. So if there is hyperacidity, if there is more of acid, sometimes this acid may travel here, and in the long run, it may form ulceration. So this rare phenomena is known as Michel's diverticulum. And what happens if there is an ulceration and there is hyperacidity in this area? Sometimes this flows into the intestine and there is formation of duodenal. If it is not diagnosed properly, not treated properly, then there are chances that this may lead to duodenal ulcer because of the flow of this acid into the duodenum. Now let us see acute gastric ulcer, very rare, not very common. So acute gastric ulcer is diagnosed when suddenly patient comes to you and they are recognized when they cause hematemesis. Patient will tell you, oh, I got one vomiting yesterday and there was some blood coming out. And after that, everything is over. But if there is one or two or three instances like this, that the patient says, no, there is no problem. So, but I vomited and there was blood. So that is acute gastric ulcer. And mostly it has been observed that when the patients are admitted in ICU, due to the stress factor, due to the tension, this acute ulceration can take. So there will be curling ulcer. There are two types. One is in the fundus and body. One is in the duodenum. In the duodenum, it is mostly after the delivery and pregnancy. So not very common, but this is the first type of ulceration. Second is chronic gastric ulcer. So this is, you see, ulcer in the stomach, ulcer in the duodenum. What will be the difference? If ulcer is in the stomach, when you eat something, it goes into the stomach within 30 minutes. So there will be pain after 30 minutes. There is periodicity. The patient will say, whenever I take something, after 20 to 30 minutes, I get pain here. So there is epigastric pain, which is aggravated after eating and which is having periodicity. Timing is there. And there is vomiting because the stomach is having pain, the stomach is not able to digest it, the stomach is not able to keep it, there is vomiting. So there is hematemesis, 60%. There is melena, passing of blood with the stool, occult blood. So that is 40%. So in case of gastric ulcer, hematemesis versus melena is 60 into 40. There is a good appetite. As the patient is not able to eat anything, patient is eating, it is going to the stomach, it is vomited out. So when it is regularly vomited out, there is weight loss. Deep tenderness in the midline of the epigastrium above umbilicus. There is deep tenderness in the stomach above umbilicus. So deep tenderness because of presence of ulcer. These are the main features of a gastric ulcer. Now I'll have to differentiate from the duodenal ulcer. If the ulcer is in gastric, I told you that patient will eat, it will reach the stomach in half an hour. So there is always pain, say about half an hour after eating. That is known as periodicity. Epigastric pain, aggravated because there is acid, there is ulcer, and you are eating food. The food, when goes to the stomach, it stimulates the secretion of acid. Then only it will be digested. So there is increase in the acid, so that acid goes and irritates the ulcer. So there is severe pain. Next is the duodenal ulcer. It will be also periodic when the food reaches the duodenum, say after 40 minutes, 50 minutes of eating. So there will be pain in the abdomen below the epigastrium, not in the epigastrium, in the duodenal pylorus area, but there will be periodicity and pain will be 1 to 1.5 hours after eating. If the pain is after half an hour, case is gastric ulcer. The pain is after 1 and 1.5 hours, the pain is. The duodenal wall is very weak. The stomach wall is very thick because it contains acid, it retains acid for a very long time. Duodenum wall is very weak, so there is severe pain. So there is pain, severe, patient has to double up and relieved by eating. Why it is relieved by eating? In case of gastric ulcer, it was aggravated by eating. But in case of duodenal ulcer, it is relieved by eating because when the patient eats something, it goes into the stomach and neutralizes the acid. So when the acid is neutralized, it mixes up with the food, helps in the digestion of the food. The duodenal ulcer pain is better. So that is why the patient of duodenal ulcer will always try to eat something after some time. Every 1.5 hours, every 2 hours, he would like to eat something, some small, because it goes into the stomach, it neutralizes the acid, and the patient feels better. So there is pain, there is appetite is good because food is relieving him. In gastric ulcer, the food was aggravating it. In duodenal ulcer, the food is relieving the patient. That is why the appetite is very good. There is no weight loss like gastric ulcer. and localized deep tenderness in right hypopontic. So I think you are able to understand the differentiation between the gastric ulcer pain and the duodenal ulcer pain. The periodicity, the timing, the intensity, relation with food, all these are different in both cases. These are the complications of peptic ulcer. Most dangerous complication is perforation. This is the perforated stomach. This is the perforation in the duodenum. And mind it, if you doubt, even 1%, don't take this case. It is fatal because there will be, after some time, there will be peritonitis developing. And you cannot cure peritonitis without surgery. So always, this is complication, one complication. This is another complication and very common complication. Perforation is uncommon. Pyloric stenosis is very common. If a person is not being treated properly for a case of duodenal ulcer, what happens? A person is having duodenal ulcer. This duodenal ulcer is being healed by nature, by medicine, by itself. But we know wherever there is ulceration and wherever there is healing, there is formation of scar. In our skin also, whenever ulcer heals, there is scarring. So duodenum is a very small passage, very narrow passage. If you are having 2, 3, 4 ulcers and they start healing and there is scarring, so this scarring will narrow down the passage of the duodenum. You can see. These are the scar tissues. These are the scar tissue. This is the duodenum, pylorus, and this is stomach. This is duodenum. So in this area where the duodenum starts, there are formation of ulcerations, and these ulcerations, when heal, they form scarring. You can see this is the real picture where the passage is closed. This passage is completely closed by the scar tissue. So what will happen? If there is pyloric stenosis, whatever the patient will eat, will that go down? It will not go down from this area. So it will remain here. It will remain in the stomach. The food will remain in the stomach for half an hour, 1 hour, 2 hours. When this capacity will not able to retain it, then there will be severe vomiting. This is the diagnostic feature for pyloric stenosis. The patient will eat, but after few hours, when it will not be able to retain it, there is severe vomiting. That is, severe vomiting is known as projectile vomiting. It will throw out very heavily from the mouth because now the stomach is not able to retain. This part is not able to retain it. So if this part is not able to retain it, it will go back from the stomach to out. So this is a very serious condition, almost operative case. In homeopathy, we are having one specific medicine, and Dr. Borik has praised this very nicely, that is ornithogala. Ornithogala mother tincture is one of the best medicines, and I have helped some patients when the stenosis was small, not very severe. Ornithogalam has helped. Ornithogalam, hydrostis. These are the two medicines which will help you. And now one of the most serious complications, when there is you can see there is perforation of the stomach and the content of the stomach are coming into the abdomen. Stomach will burst, the content of the stomach will come into the stomach abdomen. Below the peritoneum, there will be infection, there will be severe inflammation, there will be pain, there will be death. Unless until it is operated. You can see this under the peritoneum, the food particles are. This is the intestine, this is the peritoneal cavity, and under the peritoneum, from the burst ulcer, they are coming out. You can see this is the punctured peritoneum, and they are keeping out. So this is the stomach, it got punctured, it is coming into the peritoneum. The abdominal peritoneum, under the abdominal peritoneum, you will have this kind of complication, a very serious condition, severe pain, swelling of the abdomen. Immediately send him to the hospital because it needs surgery. immediate surgery. And next, a very rare complication is there, which is malt lymphoma. I will not discuss this much. There is chronic infection with H. pylori causes persistent inflammation in the gastric mucosa. Very correct. This long-standing inflammation leads to development of mucosa-associated lymphoid tissue. That's malt lymphoma. Mucosa-associated lymphoid tissue, dangerous condition, but not common. So it is not very common, but very rarely you may find a case. And this is, of course, a case which normally, if the gastric ulcer is not treated properly, there are chances, I'm not saying for surely, but there are chances that this ulceration may be converted into gastric cancer. A very painful and very serious condition. You can see the condition. This is the ulcerative tissue. So it is very difficult, very painful condition. You can see this. These are the cancerous tissues. So there are chances of formation of gastric carcinoma in case when the gastric ulcer is not treated. And this carcinoma and this peritonitis, especially peritonitis, it may lead to a condition which is almost fatal and is known as shock. The next condition, complication, most difficult complication is shock. So there is massive upper gastrointestinal bleeding, severe hematemesis or melena leading to hypovolemic shock due to acute blood loss. So there is hematemesis. The patient is regularly vomiting, not being treated properly, not being cured properly. Whenever he eats something, he is vomiting. So there is less of volume. So that is hypovolemic shock. And second, which I already told you just now, there is perforation with peritoneum. There is leakage of gastric duodenal contents into the peritoneal cavity causing septic shock and circulatory collapse. So all these two conditions are very, very dangerous, very serious conditions, and it must be taken care immediately. So these are a few complications. I hope you understand everything now. It should be very clear to all of you. The most important part, which I told you, that differentiation between gastric ulcer and duodenal. Please try to understand that, because in the clinic you will have to diagnose this with the symptoms only. Not all patients are going for endoscopy nowadays. They are avoiding endoscopy because of the complicated procedure. So by the symptoms only, you will be able to diagnose it properly. That is, in gastric ulcer, there is periodicity. Duodenal ulcer, there is periodicity. Gastric ulcer, there is pain half an hour after eating in the epigastrium. Duodenal ulcer, there is pain after 1 to 2 hours after eating in just below the epigastrium. There is doubling of pain. In the gastric ulcer, there is no doubling of pain. There is pinpointed pain. There is vomiting immediate after eating in gastric ulcer. In duodenal ulcer, there is no vomiting, very rarely, because the content of duodenum cannot come from the mouth very easily. That is why there is no vomiting in case of a duodenal ulcer, but in duodenal ulcer, the bleeding will be mixed with the stool and it will come out as fecal outcome. If you go for a stool test, there will be presence of fecal occult blood in case of duodenal ulcer. Very rare cases, in case of duodenum ulcer, there may be vomiting if it is first part of the pylorus. So there may be vomiting, but this vomiting will be unlike gastric ulcer. Gastric ulcer is immediate vomiting. Duodenal ulcer is projectile vomiting. After waiting for some time, there is projectile, very forceful vomiting. The same which is like in pyloric stenosis. These are few things which we wanted to discuss. Now, the diagnosis. How will we diagnose a case of peptic ulcer? So nowadays, this is written here, but nowadays the only perfect test for diagnosing a case is endoscopy. Most common, most perfect test is endoscopy. Nobody goes for barium meal nowadays or histology except when there is doubt of cancer. And urea breath test is also one test which can confirm the diagnosis of ulcer. So barium meal, what is barium meal test? There is a liquid, barium liquid. This is given to the patient. He drinks then on a regular timing, the X-rays are taken. After half an hour, after 1 hour, after 1.5 hours. So as the barium passes the stomach and intestine, this is the shadow of the barium. So there is a projection you can see here. There is a narrowing of the shadow. So this narrowing of the shadow indicates that there is presence of ulcer. In the previous times, this was the only test, barium meal. Whenever you go to a diagnostician, they will say, oh, please go for a barium meal X-ray, because endoscopy was not common. So this case is there. When the barium is coming down, it is narrowing down and then comes back to normal. So this area is having ulceration, and this is an endoscopy of the same case. So this is the endoscopic report. This is narrowed down. There is narrowing down. This narrowing down comes from the barium meal. So endoscopy is, barium meal is clear. Histology is taking the tissue and taking a biopsy. And there is the urea breath test. What is the urea breath test? Urea breath test is, now what happens? Patient is given one solution of urea to drink. When he drinks urea, in the stomach, it is broken down into ammonia and carbon dioxide. Then the patient is asked to breathe in a sac. It is breathing in a sac. When it breaks down, and if this container is having ammonia, if it is having ammonia and carbon dioxide, if it confirms the presence of ammonia and carbon dioxide, it means there is formation of ulcer. So this also is not very confirmatory, but nowadays urea breath test is coming in a very modern way. Within a few months or years, it will come. So then there will be no need of endoscopy. So endoscopy means they put the pipe inside and go the painful procedure. But urea breath test is coming in a very strong way with some other procedures, so where only breathing out will confirm the diagnosis of urea gastric ulcer. So I think this is all for today. I'm very thankful for you for a patient listening. In the next lecture on next Tuesday, we will discuss the management, chronic management, miasmatic management, and the medicines for peptic ulcer. Thank you very much.
Yes, sir. As usual, the first part is really dedicated to physiopathological aspect of the peptic ulcer, and you have narrated this in a beautiful way, giving all details, and then what are the tests to be done, and everything is explained nicely, sir. I hope we will have a session that is coming on 31st, that is
Yes.
coming Tuesday.
Yes.
So to come up with the medicinal aspect as well as some of the cases, some of the successful cases, I hope, sir. Because we need successful cases to be published among our YouTube, so that more people will be able to know what is happening with homeopathy in the treatment of peptic ulcer.
I'll try my best.
Okay, sir. Those who want to participate in discussion may please raise your hand so that we can allow you to unmute yourself. Is Dr. Selby, do you want to speak to sir? Selby? If anybody want to speak, please raise. Only few minutes remaining. Sir, what is nowadays most of the people used to go to these gastroenterologists, and they are doing all test, and after taking their medicine, they are coming to us. This is the way that we find. What's your opinion on that?
Actually, they usually go for the best test, that is endoscopy. And if it is confirmed that there is an ulceration, they may go for histopathology to find whether there is H. pylori present or not. And there are some good antibiotics, caromycin and some other medicines are there, which are very effective against the H. pylori. So they treat the only H. pylori. So H. pylori is treated, then they give some medical antacids to heal the ulceration, and gradually the patient feels better. That is a successful part of treatment.
Yes, sir. And Dr. Sabi from Lucknow want to speak to you, sir. Yes, Dr. Sabi, you can speak.
Yeah. Thank you so much, Dr. Kulwant Singh. It was very nicely explained and very in a depth it was explained.
Thank you.
And in peritoneal stenosis, you had suggested medicine ornithogalum, mother tincture.
Yeah, pyloric stenosis.
Pardon. So, second medicine was hydrostis, I think.
Yes, hydrostis. So these are two important medicines, but there are so many other medicines.
Yeah, so many other medicines, but this both are in mother tincture.
Both are in mother tincture form.
Thank you. Thank you so much. Thank you so much.
Dr. Sabi, please share a number. If you are willing, you can also come over here and make your presentations here.
Actually, I don't give presentations.
Okay, because
Thank you so much.
Okay, thank you. You are from Lucknow.
I am from Lucknow. Yes, please.
Okay. How many years of experience?
In 80, I completed in 84.
Okay.
And from Singhbhum Homeopathic Medical College, Singhbhum, Jamshedpur.
Okay.
And Dr. Kulwant Singh was my teacher over there. Now he's a principal.
Okay. Okay. That we can understand that, sir. It's a legend in this field.
He's a legend. He's a legend, definitely.
Definitely, because the power, even he is using all the latest technologies.
Yeah, that's true. That's true.
Even young dynamic doctors are finding it difficult to make such PPT for presentation.
Correct. Thank you.
That's the power of sir. And
yes.
anyway, thank you all. And thank you, Kulwant Singh sir, for coming over here, and Dr. Serbi for making your time. You can say what a thanks to the session, Dr. Serbi.
Yes. Thank you so much, everyone. And thank you so much, Dr. Kulwant Singh, for giving a wonderful session. And we hope that next session, which is a medicine part, it will be a fantastic one and good for our practice. It will be helpful to all of us. Thank you so much.
Yes. Thank you, Dr. Sabi. Thank you, Professor Kulwant Singh, sir, and those who attend the session. Tomorrow we are uploading the session so that you can share it with your friends. Also, tomorrow we will have a session from Dr. D.H.M. from Bangalore. Thank you all. Good night. Over to Dr. Mariamma John to moderate the Malayalam session.